Eric, are you able to check your text messages real quick?
Did you send me a message?
Just now.
Yep.
Okay, just so you know.
Okay, I see that.
Okay. All righty. Gonna give it a few more minutes, you guys. We have people still joining. Just 2 more minutes. And good morning, everyone. So we're going to have the chat open. Everyone's mics are turned off right now, but please feel free to put any questions you have in the chat. Dr. Matei will go on with his presentation, and we will answer all questions at the end, unless he wants to jump in and answer them during the process. But please put any questions at all into the chat, and we'll open that up. And I'm going to put good morning, everyone, so you see the chat. Okay. A few more minutes here. A few more. Let's just go a few more seconds. Okay, I'll keep admitting people, but in the meantime, I am going to introduce our speaker. So our speaker is Dr. Eric Matei, and Eric is the Residency Program Director, PGY2 Clinical Pharmacogenomics at Mayo Clinic, Rochester. And Dr. Matei is a clinical pharmacist passionate about improving patients' medication experience. Dr. Matei has been instrumental in the implementation of the Pharmacogenomics consult service at Mayo Clinic by utilizing cutting-edge gene-drug interaction to improve medication experience and decrease medication toxicity. Prior to his transition as pharmacogenomics pharmacist, he served as a specialty pharmacist in charge of growth hormone deficiency, primary immune deficiency, and hepatitis C to ensure appropriate medication dosing and patient education. So Dr. Matei, welcome and thank you so much for being with us.
Thank you for that warm introduction. I wish I could see all the people who are joining, but thank you all for taking time out of your day to listen to this webinar. And I've titled today's talk, Pharmacogenomic Implementation, Challenges and Lessons Learned. I have no disclosures, but if in the future you have any contracts or collaboration that you would like us to get together, don't hesitate to give me a call. So today, my hope is that by the end of this webinar, we'll have a brief, introduction to what pharmacogenomics is as it applies to clinical practice. The focus of today's talk will be heavy on implementation, pharmacogenomic implementations, and then the lessons learned from the pharmacogenomic implementation initiatives that, I've picked a few that has actually taken place here at Mayo Clinic. So a high level of, Mayo Clinic, for those of you who may not know where Mayo Clinic has its, I would say, buildings and practice. So we are located in Rochester, Minnesota, Jacksonville, Florida, and Scottsdale, Arizona. We also have over 70 Midwest communities spread across Iowa, Minnesota, and Wisconsin. And I have been at Mayo Clinic for 20 years. For the past 25 years, Mayo Clinic continues to maintain a position, either on top or near the top for the best hospitals in the country. So funneling down, as an organization, Mayo Clinic sees about 1.2 million, patients on a yearly basis. I don't know if there is a treatment out here that Mayo Clinic does not try their best to help with. And if we look at our staff, we have about close to 65,000 employees, and majority of the employees are within the administrative and allied health, which pharmacists do belong to. Again, falling down, so if you look at our Department of Pharmacy, I want to highlight down here the ambulatory care and medication therapy management services. There are about 56 MTM pharmacists here alone in the Minnesota region, and about 21 MTM pharmacists in Rochester. One will say, Eric, why are you telling us all of this about Mayo Clinic? I think as I get deeper into the presentation, some of these numbers will make sense. So in general, what is pharmacogenomics? I think most of us on this webinar will agree that it is the study of the generic variations that influence an individual response to medications. If I'm to just pick a medication such as, let's say, sertraline, with us coming out of COVID, the number of patients who mental health is an issue is pretty high. And so just for, completeness sake, as we look at this diagram here, sertraline, as we all know, is metabolized by CYP2C19. And in general, most patients who are normal metabolizers, one will, all things being equal, will say that if sertraline is given to a patient or patients who are CYP2C19 normal metabolizers, those patients are expected to have the desired response, meaning improvement in, let's say, depression. And for some patients, they may not have any response, right? It could be that those patients might be ultra-rapid metabolizers and they're clearing sertraline pretty quickly. And you may have some patients who may have, side effects if they are poor metabolizers. Again, this is just for an example, picking sertraline as the drug of. And those patients may accumulate the drug and have side effects. So again, in general, if you look at the simplicity of pharmacogenomics, meaning the drug-gene interaction, looking at specific phenotypes across the spectrum, depending on the patient's, phenotype, the desired response to a medication, those that have drug-gene interactions, may either be desired, no response, or potential side effects. So like I said, majority of what I'm going to share today has to do with implementation of pharmacogenomics. Now, from my experience here at Mayo Clinic, I would say that the required elements for the implementation of pharmacogenomics are the following. I'm sure there are others that I might be missing, but having the right expertise, leadership support, the infrastructure, education, translational research, and the clinical application of all the things that I've talked about, I think is critical for a successful implementation of pharmacogenomics. Now, when we look at the Mayo Clinic model for pharmacogenomic implementation or operation, if you remember, I just talked about leadership support. Leadership support at Mayo Clinic has been quite solid and has helped with the pharmacogenomic governance across multiple clinical departments. Now, once I go through this slide, I'll give you a quick workflow of how this model works. The involvement of our lab is quite critical to ensure that there are standardization and migration of the pharmacogenomic test results into our electronic health record. Education is critical. So again, as I go through the slides, I'll share more about what Mayo Clinic has done in the space of education. Pharmacogenomic knowledge, meaning management of the actionable pharmacogenomic results, and how our clinical decision support is also critical in the implementation process. Now, all of this that I've talked about will be of little significance if long-term maintenance is not part of the game plans. And so, again, this is the Mayo Clinic model for pharmacogenomic operation. There are some relevant and notable milestones that CIM, which is the Center for Individualized Medicine, from about 2012 till today, have played a pivotal role in the implementation of pharmacogenomics across Mayo Clinic enterprise. But for the sake of time and to ensure that I do a good job of sharing some of this experience that we've had, I focus on a few which I've highlighted here. So if you look at the drug gene rules, which our pharmacogenomic task force was critical in ensuring that we had. And I'll share a little bit of light on our, predictive genomics service and some of the lessons that we learned here. If there was time, I would have gone into our Mayo Clinic Nigeria experience. There's a paper out there on this topic. And so for those of you who are interested, you can maybe do a little bit more digging to find more about this. The lessons learned from our predictive genomics service, we then, sometime within 2016, 2017, we had the pharmacogenomic expansion project. And then, again, the lessons learned from the pharmacogenomic expansion project, in addition to other factors, helped with the right 10 study and the clinical implementation plans that ensued thereafter. So I talked about the right 10K, but before I go in depth into the right 10K, I think it's important for me to share a little bit light on the right protocol. The right protocol, what Mayo Clinic did was we had about 1,013 biobank participants. And for that group, 84 genes were sequenced. Of the 84 genes that were sequenced, 5 of these genes were clinically reported into our electronic health record. Now remember, when this study was done, the pharmacogenomic results were scanned into the electronic health record, meaning that clinical decision support tools were not in place at that time for rules to fire. Okay. Now, this helped us figure out that over time, clinicians became very frustrated with the fact that patients were coming to the clinic and saying, yeah, I was part of a study and I was told that my results were going to be utilized moving forward with my plan in terms of healthcare. But clinicians were finding it quite difficult in identifying these drug genes or these pharmacogenomic results that had been scanned into the medical record. This led to what I call the drug gene electronic health record implementation. And I'm not going to go through all of what Mayo Clinic did here, but I want to highlight a few key members here. So our laboratory that help with the pharmacogenomic testing and the interpretation of those results, the pharmacogenomic task force, as well as the medical practice were key in the implementation of the drug gene pairs. Now, to give you a quick workflow, like I promised, when CPIC, which is the Clinical Pharmacogenomic Implementation Consortium group, comes up with what I'll call a guideline, right? What the task force will then do is the task force will contact the medical practice for guidance as to which of the pharmacogenomic drug gene recommendation or guidelines that clinical practice will like to have within their practice. Once the medical practice provides the specific, let's say the only one poor intermediate drug gene pairs incorporated into the clinical decision support rules, that it comes back to the pharmacogenomic task force, and the pharmacogenomic task force will work with our pharmacogenomic education team. The pharmacogenomic education team will then ensure that the Ask Mayo experts, which is a knowledge content board, create the right message And then that information is sent to our clinical decision support tool for approval and then implementation. So just to give you a snapshot of how our drug gene implementation group works. Now, so far, I've talked a little bit about our clinical decision support group. I've talked a little bit about our pharmacogenomic task force, and I've laid a little bit of the framework of what happened somewhere between 2012 to about 2018, 2019. One of the things that I highlighted when I went through the time frame was the pharmacogenomic profile service. Now, the pharmacogenomic profile service, what Mayo Clinic did between 2014, 2016 was a test of concept, right? Could we, after the right protocol, really implement pharmacogenomics into clinical practice? So what we did was we partnered with our internal medicine clinic. And what this workflow shows is that patients who were interested in pharmacogenomic tests, which usually then occurred when the pharmacogenomic pharmacist identified these patients in conjunction with the internal medicine champion. If the champion felt like, well, based on the patient medication list, pharmacogenomics could be of help, what then happened was that the pharmacogenomic pharmacist received an order to meet with the patient. If the patient, during this time, the consultation was twice. The patient would then meet with the pharmacist will review general overview of what pharmacogenomics is. If the patient was interested, blood sample, back then we're using blood sample. Blood sample was then collected, sequencing was done, or genotyping was actually done. Analysis and results were incorporated into the medical record, and then the pharmacist then met again with the patient to review the pharmacogenomic results. Now, at the end of this pilot, what we realized was that one, back then the cost of pharmacogenomic tests was way too high. Pharmacists meeting with patients twice. Most patients, after a survey that was sent out, said it was nice to go over what pharmacogenomics was, but at the end of almost each consult, the patients were saying, so how can my genes help me? And at that point, pharmacogenomic testing had not been done, right? So it created a lot of what I will call less value for the patient, a lot of time spent with the patient from the pharmacist standpoint. So the lessons that we learned during the profile service was that one, pharmacogenomic testing at that high price back then in 2013, 2015 was not affordable. It was not scalable. Pharmacists meeting with the patient twice. I know there are some institutions and maybe organizations that continue to see patients before and after, but based on the studies that we did here at Mayo, most of our patients were saying they really would like to have the pharmacogenomic results and have a single consult with the pharmacist. Now, because the clinicians or physicians were not the ones who were ordering the pharmacogenomic test, they were actually not very comfortable when the results came back. So the adoption of clinicians based on the model that we had with the pharmacogenomic profile service, we realized very soon, and when I say we, the Department of Pharmacy and the Center for Integrative Medicine realized that if we really wanted pharmacogenomic to be acceptable across the enterprise, we needed to ensure that our physician champions were comfortable. So what did we do then? Well, we decided to move forward with what I call the pharmacogenomic expansion project. Remember, I had shared with you that cost was an issue. And back then, One Ohm, which is a CLIA-approved lab here in Minnesota, came up with their RightMed pharmacogenomic tests. It had 22 genes on there, and the price had reduced from, remember I was sharing with you, almost $3,000 worth of a test. Price came down to $250. And if you all remember when I talked about the right protocol, there wasn't a pharmacogenomic report. It was, scanned into the medical record. But then now, working with OneOme, what we were able to do was that the report, the results were incorporated into discrete data, which helped our team to come up with a way for our clinical decision support tools to start firing. Okay, so the IM clinic or the internal medicine clinic or the pharmacogenomic expansion project, the lessons learned from the initial pilot, which is the profile service, what we then did was we moved into an e-consult process. We also decided to train more pharmacists, and so we went from one pharmacogenomic pharmacist to two pharmacogenomic pharmacists. And then, like I shared earlier, the interface for discrete results, working with our lab partners here at Mayo Clinic and OneOme, that process also started with the pharmacogenomic expansion project. Now, remember, I talked about clinicians not being comfortable with the pharmacogenomic result because they were not the ones who were ordering the test with the pharmacogenomic profile service. With the expansion project, what we did was, the Center for Individualized Medicine paid for the OneOme result as well as the test, the e-consult. And an e-consult is basically an electronic review of the patient medications as or against their pharmacogenomic result. And if there are any actionable results, pharmacists then complete the pharmacogenomic e-consult, and that results or recommendations is then sent to the ordering clinician, right? What we also did was we then figure out department champions who found value in pharmacogenomics in their practice. The expansion project was a combination of predictive and diagnostic pilots, but I think for the sake of this talk, I'll be sticking with the predictive piece of the pilot. Now, these are examples of some of the expansion projects that we undertook. But if I'm to highlight maybe two of these expansion pilots, one that sticks out is the PEDS GI. Now, with PEDS GI, with a study, what they did was they identified patients who were diagnosed with GERD. And usually, these patients will have an endoscopy to rule out anything else but GERD or major acid reflux. These patients were usually then prescribed either a proton pump inhibitor, and for some patients, if their symptoms were not managed within a certain time frame, they will have a second scope to try to figure out what is really happening. What PEDS GI did was, as part of this expansion project, was they had their patients go through, or the patients who were part of the study had pharmacogenomic testing done before the scoping. And so for patients who were ultra-rapid metabolizers, those patients were then given that option of having a higher dose of their PPI. And at the end of the study, some of the patients, I think about 30% of the study participants who were ultra-rapid metabolizers, who were provided higher doses of the proton pump inhibitors, we did see a better medication experience or resolution of their GERD symptoms. Another interesting study, I think for the sake of time, and these two studies have been published, GI motility clinic, that was another interesting one. But I think for the sake of time, I'll just highlight this PEDS GI. And today, based on the experience, they've actually incorporated the PEDS GI has incorporated pharmacogenomic testing as part of their workflow. So again, the lessons learned from the PGX expansion project was that because clinicians were now ordering a pharmacogenomic testing for the example that I just provided, if you think about the gastroenterologist who is now seeing CYP2C19 and understanding the relationship between that gene and medication, after a period of time, they became more comfortable just interpreting that result and utilizing the association between CYP2C19 and PPIs in their clinic. It did not mean that they were comfortable with all the other genes, but at least for the genes that, or the gene that was of most significant, they were more comfortable with that. So it increased clinician utility. Again, since pharmacists were not meeting with patients twice, we figured out that with the e-consult process became more scalable, and the champions, became grassroots speakers for the expansion of pharmacogenomics across the enterprise. So shifting gears a little bit here, I talked a little bit about the right protocol, and the lessons learned from the right protocol did help with the expansion to the right 10K. Now, the right 10K, again, what Mayo Clinic did was they had 10,000 patients recruited from the Mayo Clinic Biobank. In this case, 77 pharmacogenes were sequenced. In the initial protocol, we had 5 genes reported into the EMR, but in the right 10 protocol, we had 13 genes incorporated into the, EMR. Now, we were able to do this because at this point, we had, implemented the clinical decision support tool. Discrete data from the lab was being, dumped straight into the medical record for best practice advisories to FHIR. Okay, and just to highlight here, the right 10K protocol had to do with Mayo Clinic, One Ohm, and then Baylor College of Medicine. Now, if we look at the research initiative of the right 10K study, it was to assess the impact of pharmacogenomic clinical decision support, because now we had it built, right? That's preemptive pharmacogenomic testing improve patient outcome. Is the preemptive approach a cost-effective strategy? Now, for most of us on here, our and for most of my colleagues who practice pharmacogenomics on a daily basis, our hope is that a day will come when preemptive pharmacogenomic testing becomes the way to go. That way, if new medications are prescribed and they are drug gene as the association or recommendations, those actions can be taken instead of the reactive approach that I think currently most clinics are practicing. So the study was to assess if what I just said was cost effective, right? And then expand the number of patients with pharmacogenomic results. And then expand the awareness and knowledge of pharmacogenomics across all providers here at Mayo Clinic. Now, if you listen to everything that I just said, most of the study participants, their sample was taken from a biobank, right? So the issues was that the clinicians were not the ones who were ordering a pharmacogenomic test. However, the results were going to be incorporated, those 13 genes that I talked about, were going to be incorporated into the study participants' medical record. And because now we had the clinical decision support and the patient portal in place, the patients were going to be receiving these messages, but then their clinicians were not aware of the results being in the medical record because they did not order the test, right? Providers were also not prepared to handle the results. We hadn't trained all these clinicians about the utility of pharmacogenomics. Med lists, as we all know, may not be current. And then pharmacists, funny enough, were not involved in the initial process of this right 10K pharmacogenomic implementation project. Other issues, if I don't know how many of you remember, but One Ohm and most pharmacogenomic reports had this blue, red, yellow, and green session, and there were patients. Some of the issues that were raised was that patients who might have been stabilized on medications that were listed in the red session might take actions without talking to their clinicians. And that's not all medications that showed up in the red will have rules being fired on them, because if patients were stabilized, then there was no need for action to be taken. And I think I've highlighted that last point where pharmacists were not also prepared. When I say all pharmacists across the enterprise were not prepared. So these were, at least a few of the issues that were raised, as part of the rollout of the Right 10K. So what did we do as pharmacists with some of the issues that I've talked about? What we did was that we rolled out a train-the-trainer model, where the pharmacogenomic pharmacist created an education and a quick reference guide that all the members that I've listed here, so the early adapters were pharmacists who were very enthused about the implementation of pharmacogenomics, and then they joined the pharmacogenomic pharmacists in training our medication therapy management pharmacists. Then we trained our supervisors, and then the supervisors served as what I'll call coordinators, right, for both the outpatient and inpatient pharmacist. The next slide here does show exactly what I just talked about, but then we did the training across multiple phases. Now, the total time that we spent, if you look here, the total time that we spent for, or let's say the average was about 24 minutes per e-consult, okay? But at the end of the study, what we realized was that it took about 1,200 hours and over 11 months to complete these e-consults for the study participants that had actionable pharmacogenomic results. Now, if you think about this led, Mayo Clinic to the pharmacy department to decide to expand the number of pharmacogenomic pharmacists that were serving across Rochester. So with this information, the number of FTEs went from 2 to 3 to meet that high demand that was being anticipated at that time. I think I've already shared a little bit here, but if you can look at the pharmacogenomic pharmacists who were very comfortable dealing with pharmacogenomic test results, took less time compared to our inpatient pharmacists who, usually do not utilize pharmacogenomics on a daily basis as part of their practice. However, with the quick reference guide that we created, what we realized was that we were able to then train what I'm going to say over, I think that number was about 289 pharmacists across our Rochester campus. Now, as part of the rollouts, when pharmacists started sending pharmacogenomic recommendations to the primary care physicians, one of the things that the primary care physicians initially wanted was send us everything under the sun. We want it in your recommendation, and we will figure out which ones to act upon. After a while, the primary care clinicians came back and said, the recommendations, the ones with no actionable results, please take them out, because spending about 30 seconds on the e-consults. So what pharmacists did was that we condensed our recommendation and made it quite concise to the clinical recommendations that had actionable results. Down here, I talk about the dry gene pairs with limited evidence. Again, for those of you who might have seen the initial one-home report, there were quite a number of medications that had maybe 1 or 2 studies back in them. There wasn't, any CPEC recommendations for some of the medications. And so what we did as part of the lessons learned was that we removed some of these medications from our e-consult template. And then funny enough, there were medications that were patients were applying, such as creams that had, a good example was diclofenac was showing up quite a bit, and there were some clinicians who were asking, how do we act upon this? And so some of those medications were also taken out, except for 5-fluorouracil. And I think there are some guidelines out there that says if, depending on how much of this cream is being applied over a total body surface, it's important to be mindful of if the patient has the DPYD variants, to be mindful of that. So some of the lessons learned from our Right 10K implementation. And it continues. I want to make sure that I highlight some of these, I think, for general awareness for anyone who is thinking about implementing, especially across a large health system. So what the clinicians told us is that about 30% of clinicians noted pharmacogenomics was part of their formal training, but they hadn't utilized it in a very long time. Okay, so that told us, as part of our lessons learned, was that we needed to create an education to help our clinicians moving forward in becoming comfortable if we wanted the adoption to be high, right? And only 9% had talked to their patients about their pharmacogenomic results. Majority were not comfortable, so they had not spoken to their patients about the pharmacogenomic results. Half of the clinicians did not plan to use it, the pharmacogenomic results, once again, because of the level of, I'll say, lack of comfort with these results. And then 7% expected to order or recommend a pharmacogenomic test for their patients in the next 6 months. Now, almost everything that I'm saying here goes down to the point of comfort level of the clinicians and lack of education and resources that clinicians could then jump to if they needed help with the pharmacogenomic results. So with that in mind, we went back to the drawing board, and again, the lessons learned always help us figure out what to do next. We had the pharmacogenomic competency models for our pharmacist group, but over time, what we realized was that the recommendations and guidelines keep changing sometimes, year to year, based on where the science is taking us. So one of the things that we did as part of, I would say, evolution of education is Mayo Clinic did come up with a pharmacogenomic certificates course, and I'll talk a little bit about that later. But then to help our clinicians with adoption, an experiential pharmacogenomic education where the clinicians had their pharmacogenomic testing done. And then what we did was, we spent like half a day with a subset of the clinicians to review their results. And one interesting story here was that there was a clinician who, I would say, wasn't an early adopter of pharmacogenomics. And as I was going through their pharmacogenomic test result, I said, based on your pharmacogenomic result, if you were ever to need warfarin, you may need maybe half of the usual, instead of 5 milligrams, you would need a really low dose. And for a split second, he sat up and then said, "What? I fell while cleaning, my gutters, my roof gutters, and developed a clot. And I was actually given a normal dose, and I've been bruising and bleeding all over the place." Okay, and this person now became, went from, I'll call them a late adopter to an early adopter within a split second, and for many years became a spokesperson for pharmacogenomics. And so this is where, in some cases, the experiential education, once clinicians are able to relate to their pharmacogenomic test results with some medications they might be taking or might have taken in the past, does help with the adoption of pharmacogenomics. Other things that we did with respect to the lessons learned from our experience was that we ended up with multiple ground rounds, in-service presentations, and lunch and learns. Okay, so I talked about the creation of the pharmacogenomic certificates program. Now, if you remember, I talked about our pharmacists ranging from outpatient pharmacists, inpatient pharmacists, MTM pharmacists, and the list goes on. But what we decided to do across Mayo Clinic was, what is the minimum requirement that all pharmacists needed? That way we could serve as the education resource for other clinicians within the multiple practice or specific practice sites. So on the right-hand side of what I'm showing here, these are the minimum required models that the pharmacy department decided that almost all pharmacists across Mayo Clinic will have to complete to ensure that, again, they serve as leaders and resource for other clinicians. So I know I already spoke to at length about the pharmacogenomic task force, but because of the education models that I talked about, the pharmacogenomic task force then working with our education department helped with that education presentations, the ground rounds. But I think what I want to highlight here are two things. One is the pharmacogenomic mentor-mentee matching. And so for clinicians who are really interested in the adoption of pharmacogenomics into their practice, we pair them up with a pharmacist who, at a regular basis or a scheduled time, they could just talk about some of the challenges that we're having with the application within their practice, latest updates, anything to do with pharmacogenomics to help with the adoption of pharmacogenomics. And then we had this pharmacogenomic clinical decision, and what we call this is the pharmacogenomic roundtable. The pharmacogenomic roundtable happens on a monthly basis where pharmacists and other clinicians spend about an hour talking about a case. Usually we'll start with a case that was seen in practice. We'll review, what the clinical decision supports, actions that we're taking. We'll look at the Ask Mayo content, and we'll check to see if there are any new guidelines. And basically, this is just to spur the conversation around pharmacogenomics and to let other clinicians who may not be comfortable have an opportunity or an arena to discuss and ask questions to help them with the implementation of pharmacogenomics within their practice. This actually also led to what we call the Enterprise Pharmacogenomics Subcommittee, where the Mayo Clinic, the Rochester pharmacists, the health system pharmacists, and our colleagues around Florida and Arizona, we meet on a monthly basis to see how best the lessons that we've learned can help us with continuous adoption of pharmacogenomics and the spread of pharmacogenomics across the enterprise. Now, I know I shared, a little bit about our pharmacogenomic decision support. What I want to highlight here is that, as part of the right 10 case study, we were able to, there were about 4,600 alerts that were fired within a period of about a year. And this helped our Ask Mayo expert group figure out which of these drug gene pairs clinicians had a lot of questions about, which clinicians had more questions, which then helped with tailoring the education to those clinicians and to those departments. Now, transitioning a little bit, right? What is the future state? Okay, we started with the pharmacogenomic pilots. We went into the pharmacogenomic expansion project, and then the pharmacogenomics Right 10K project. And all of these things, I think I've shared with you the lessons learned and using the lessons learned to spring forward in the pharmacogenomic, I would say, advancement across Mayo Clinic. One of the things that came out of the Right 10K was our primary care pharmacist came to the pharmacogenomic task force to say, currently there's very little pharmacogenomic testing happening across the clinics within the primary care. So with discussions, what then happened was that there was increased interest in pharmacogenomics in the primary care. but they also had that lack of formal pharmacogenomic education. And so for pharmacists who were interested in the adoption and in the primary care setting, what we did was we went back to the minimum standard, or for the MTM pharmacists, they had to complete the full 16-hour pharmacogenomic certificate program. Okay. Now, I already talked about the task force, but the primary care, and this goes back to the initial one of the initial slides that I shared that talks about translational implementation. You know, the workflow within the specialty pharmacy areas or the medication therapy management services within Rochester, if we were to take those same models and apply them to our primary care setting, there's a probability that things will not work out really great, right? Because the settings are different, the clinicians are different, the way that they practice is quite different from how many things are done in Rochester. So understanding the translational implementation models, we were open to having the primary care groups form their own task force. They obviously came back to the larger universal task force within in Rochester, and then we worked with them to create all the resources that they needed to ensure that they were able to then implement pharmacogenomics within the primary care setting. So, you know, today, PGS has become a standard service offered in all 46 primary care clinics with on-site pharmacogenomic testing. I can spend a whole lot of time talking about ensuring that the local labs also had the kits that were necessary. There's a lot of work that was done in here to ensure, and again, we were able to figure these things out from the lessons that we learned when we, as part of the Right 10K, and as part of some of the expansion projects that I talked about. Today, I think in the last 12 months, the primary care pharmacists within the medication therapy management group or medication management services have had over 800 pharmacogenomic visits that have been completed by these pharmacists, something that we are very proud of. And so I think to ensure that I leave some time for questions and discussion, you know, the utility of pharmacogenomic testing in clinical practice has come to stay. There are multiple organizations across the United States, and if you want a list of that, CPIC has a really good list of all the institutions that have implemented. I really think that it's come to stay and is going to continue to expand. You know, required element of pharmacogenomic implementation. I think if you are considering implementing, ensuring that you have a champion, ensuring that you have the infrastructure, ensuring that you have the education, and ensuring that you have a clinical site to apply all the knowledge, I think is quite critical. And again, the lessons learned from the, you know, the implementations that I've talked about should serve as a springboard, an opportunity to to fill the vacuums that could have been created from the lack of knowledge and the lack of, I'll say, resources, and to ensure that you know, your practice is successful. You know, and with that, I'll bring my presentation to an end here and open it up for questions.
Thank you so much, Dr. Matei. That was amazing. So we do have some questions. I am going to give them to you in the order that they came in. Number one, how do you identify and prioritize patients for PGX testing?
So that is a very, very good question. I'm going to go to what we're currently doing. Today, patients are identified based on, I'm going to choose an area such as, let's say, mental health, and thinking more about the reactive side of things instead of the preemptive. So for psychiatry, if there are patients who have tried, let's say, one or two antidepressants and have not done very well, because of the education ground rounds that we had over the years, clinicians are then identifying these patients and then offering you know, pharmacogenomic testing and then sending these patients for pharmacists to review. Another group so again, all of these are reactive. Another group will be our patients who in our pain clinic for patients who may not respond very well to, for example, let's say tramadol. Those patients are sometimes referred to figure out, are these patients poor metabolizers? Are these patients ultra rapid metabolizers? So more on the reactive side. And I think we're able to identify these patients because of the education that we've done over the years. And our clinicians have become, I'll say, aware of some of these medications that have drug gene association. I also want to go back to the Ask Mayo Expert content that I talked about. If clinicians are not aware or may not know of medications that have drug gene interactions within our Mayo Expert platform, they're able to then just type in these medications, and then there is a link there that provides enough content for them to then order the pharmacogenomic testing for these patients. Again, I wish there was a way for us to offer more preemptive pharmacogenomics testing, but one way that we've been able to do this is through the large studies, right? So offering the pharmacogenomic testing, having the results in the medical record, and then having the CDS file to alert clinicians. And so some, of this is also happening now that we have preemptive pharmacogenomic results for some patients.
Okay, wonderful. Thank you. On to the next. How did you bill for the e-consult service?
Very good question. So if you go back for the study, the Center for Individualized Medicine decided to pay for the e-consult because it was a proof of concept that we wanted to get more information to help with the expansion. Today, unfortunately, in Rochester, although we do bill for e-consults, there are for one reason or the other, we are not getting paid for even for the e-consult at this time. But we are still billing and hoping that a time will come when some of these e-consults will be paid for. Now, for face-to-face consult or some of the virtual consult, some of the insurance companies are beginning to pay using the CPT codes, the 99605 and 99606 and 99607. So some insurance companies are beginning to pay for some of the virtual as well as face-to-face consults.
Yes, indeed they are. Okay, so next question. For providers ordering panel testing for a specific indication, for example, Peds GERD, how are incidental results outside of that indication reviewed and communicated to relevant providers? Are you solely relying on BPAs firing upon med order for this, or is there a more proactive means in place?
Very, 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 very great question. So for clinicians who are, to deal with the question that has been asked, because a Mayo Clinic is using, electronic health record, EPIC in this case, what we usually will happen is that for incidental findings, and the pharmacist will then complete an e-consult. The e-consult will then be linked to the patient's primary care provider. So the primary care provider, for all incidental findings or drug gene pairs that the specialist is not comfortable dealing with, an e-consult is completed and the results are then sent, or recommendations are then sent to the primary care provider. The primary care provider is then aware and they can decide to act on it. What I have come to find out with practice is that sometimes by the time a pharmacogenomic result hits the medical record, adjustments to these medications might have happened, especially if the patient has been taking the medication for about a year or two. And so when our recommendations get to the primary care providers, it affirms some of the decisions that they might have made without even the pharmacogenomic results. With that in mind, it further spurs these primary care providers who, when patients now come to them and say, you gave me medication A, I don't think it's working very well, it helps them remember that pharmacogenomics could play a role in answering, the question about efficacy or potential side effects. So again, to answer the question, BPAs are being utilized. However, what we've done is that we then complete an e-consult to help the primary care provider be aware of those incidental findings.
Wonderful. Okay, next. To sort of build on that one, how does implementation address multiplex drug gene interactions, phenoconversion, etc.? Recently published that greater than 60% of patients taking a PGX indicated medication are taking at least one other PGX indicated medication in a separate clinical area. In greater than 61,000 PGX indicated patients, each patient was taking 1.93 PGX indicated medications per patient.
So I think this question had to do with potential drug gene and phenoconversion.
Correct.
Today, again, here at Mayo Clinic, that is where the role of the pharmacist comes to play, right? So if you look at, some of our current template, the first question that we answer is clinical recommendations based on pharmacogenomic results, okay? The second question that we have in our template is potential drug gene interactions. So for instance, if the the clinical question has to do with drug A that has a drug gene interaction, and we answer that question on top, but then we come to our second point, which is the potential for drug gene interaction. What the pharmacist would then do is that second medication an inducer, or is the second medication an inhibitor? The pharmacist, again, using their experience and the resources that are available to us, would then provide a different recommendation. If it's an inhibitor and the medication is an active medication, depending on the pharmacokinetics of the medication and potential, serious, the potential degree of the adverse reaction of the initial medication, the pharmacist would make the best clinical judgments. There are some tools out there that will help, pharmacists if they, input multiple medications to figure out, which ones are the inhibitors, which ones are the users. And with that, pharmacists can then provide their clinical recommendations. My hope is that a day will come when artificial intelligence will be able to help us in this area, right? Because as you mentioned, there are 60,000. The numbers are pretty high, and the time will come when pharmacists will not, understand and utilize their brains to do these computations of potential drug interactions and drug gene interactions. But in the future state, my hope is that a time will come when artificial intelligence will be able to pick some of this information up and provide the recommendations to, again, help our patients avoid potential major adverse drug reactions.
Wonderful. Okay. You might have already answered this, Dr. Matei, but what is the percentage adoption rate of the alerts that have been fired?
I don't have that number, but I'm going to tell you that it's pretty high. I'm going to say at Mayo Clinic it might be around 80 to 85%, and the reason for that is the education that has taken place, the utility of the pharmacogenomic, again, e-consults, and the continuous, I'll say, association, all the clinical experiences that patients are having, right? And so when these, as part of one of our pharmacogenomic, I'll say, residency QI projects, we looked at the adoption and acceptance of pharmacogenomic recommendations by pharmacists, looking at multiple clinicians, and that acceptance rate was about, I think it was about 79%, which is pretty high, right? And these were looking at patients who were taking multiple antidepressants or in the mental health arena. So it's pretty high. And I think, again, all that has to go back down to what is the relationship that you have with your clinician champions? How often are you engaged? How often are you utilizing your pharmacogenomic ground rounds or pharmacogenomic roundtable sessions to discuss the pharmacogenomics findings, and to also listen to the point of view of those clinicians who may be saying, I'm not an early adopter. Can you share more with me? And how do we ensure that we continue to show our colleagues the science that continues to evolve to help with the acceptance of our recommendations?
Wonderful. Okay, two more questions. In primary care PGX clinical consult, who is responsible to address medication changes beyond the purview of the primary care physician, the pharmacist, the primary care physician?
I think at Mayo Clinic, it is a combination of both. So most of our primary care pharmacists are embedded in the primary care practice, right? And so again, the level of trust is pretty high. Once the pharmacogenomic results recommendations are made by the primary care pharmacist, there's a discussion with the primary care provider. And again, we have to look at the whole picture of the patient. And so those discussions then lead to, usually it is the primary care providers who have the final say in the course of action that needs to be taken for those recommendations.
Great. Okay, last question. So given that you aren't getting reimbursed for e-consults, what sort of financial justification did you use to expand the PGX PharmD team?
So I think I shared there are multiple ways of justifying pharmacogenomic, I'll say, adoption. Okay, and let me give you a scenario. If you have a patient who has pharmacogenomic testing done, and the patient, let's say, has an HLA-A or HLA-B positive gene, and nobody knows about that, right? So the testing is not done. The patient is given a medication. The cost involved in managing the potential side effect of that patient can be in the thousands, right? What Mayo Clinic, has done, so looking at our Center for University Medicine, as well as our clinical groups in the Department of Pharmacy, what we have come to, accept is that we will not accept the theory of potential adverse drug reactions based on pharmacogenomic testing or the lack of, and be okay with that. And so if we are able to then save or decrease the number of adverse drug reactions that our patients who are walking into our doors may be experiencing, we will then create opportunities for our other clinicians to see more patients, right? And if they're able to see more patients and we're able to then decrease the adverse drug reaction, then I think the return on investment, we all agree, is pretty high if we are preventing major adverse drug reactions. And so that is the other way of thinking about the question about cost.
Perfect. Okay, well, that will end our webinar. Thank you so much, everyone who joined. It is wonderful to see you all here and an interest in PGX. We fight every day, as many of you do, for its progression in education. We will continue to do so. If you haven't yet considered membership, please do so. More information is available at AmericanPharmacogenomicsassociation.com. We'll be having more webinars, our PGX Coffee Talks monthly, our large conference is coming up in 2025 as well, early in California, Costa Mesa. Dr. Ruben Guerrero will be opening that with the keynote. And we're very excited that he's recently accepted that. So lots of planning going on there. We're doing a ton of things. So more and more will come out every day. But for today, Eric Matei, Dr. Eric Matei, thank you so much. You guys are setting such a standard as usual. And so we will be in touch with more things going on. Please follow us on LinkedIn, check out our website, do all that. And we will talk to you all soon. Thank you very much once again. Have a great day. Bye-bye.
Thanks for having me.